If I can have your attention, we'd like to begin our next session. I'd like to introduce to you Dr. Gary Strong. He's a general dentist, practices dentistry in Billings, Montana. He graduated from USC in 1978. He has interests in alternative health, which began in 1978. Is that correct?
Actually, 82. That's right. That's close.
Presently, he has interest in public medical research and has written several articles and materials for professionals and patients, and I believe he's handed out 3 of those pamphlets. In September of '94, which was a couple months ago, he received a fellow from the International Association of Oral Medicine and Toxicology. Turn the time over now to Dr. Strong.
Thank you. Thank you very much. I have a short ad here. What you have as samples are just some pamphlets I've put together for patient education. I started those for my own patients, and I thought, well, gee, why not make them available to others, because it saves so much time in the office if you can just hand them a pamphlet and explain it to them with the pamphlet. And actually what I do many times is I say, I will take these pictures while they're developing, you can read this. And that way it saves me having to, or my staff having to explain. That's the pamphlets, and then there's a book I put together for professional education in particular. There's 8 topics with 40 to 50 references per topic. The topics are listed on the flyer. Some of these topics I'll be discussing with our slides here shortly. I'm aware there's a wide range of experience here, so I'm going to go over some introductory material regarding mercury amalgam itself. Can we dim the lights just a little bit, please? I have slides. I don't have overheads. I'll just go ahead and begin. Dental amalgam, as we know, is about 50% mercury. I got to get used to using this thing. It's about 50% mercury, about 35% silver. Tin is about 13%. Copper varies dramatically depending on whether it's high or low copper alloys. And there's some trace metal of zinc. The size usually it contains about 750 to 1,000 milligrams of mercury. The average lifespan is 7 to 11 years, depending upon the studies you look at. Approximately 75% of restorations now being placed are amalgams. We're hoping that's going down as time progresses. There are about 100,000 kilograms of mercury used in dentistry in the United States every year. That's a lot of mercury. Mercury readily evaporates. If I were to place an ounce of lead and an ounce of mercury in a beaker on a table and leave it for an hour at room temperature, and I came back, I would find there was less than an ounce of lead of mercury. The lead would remain unchanged, of course. If I take that same ounce of lead and ounce of mercury and put it in the same beaker on the same table, only this time we had a hot plate, 100 degrees centigrade. When we came back, there might be no mercury remaining, or just a small amount. The lead would be unchanged. So mercury does evaporate. That's part of the problem. Whoops, I'm pushing the wrong buttons. I apologize.
You have to aim it, Gary. You have to aim it to the thing sitting on top of your projector.
Is it stuck? Okay, so mercury is continually evaporating the surface of the amalgams. Any stimulation, mechanical, chewing or bruxing, thermal, hot or cold, any change of temperature in the mouth, or chemical, any ionic solution, including acids in your pops, any chemicals in toothpaste, anything that changes the chemistry of the mouth and disrupts the homeostasis or the stability of the mouth chemically, will stimulate the release of mercury from the fillings. This mercury release will remain elevated for approximately an hour and a half. The American Dental Association, and all of organized dentistry for that matter, has focused primarily, am I in your way? Okay, has focused primarily on the vapors that come out of amalgam. However, there was a study done, an in vivo abrasion study, where they looked at one occlusal amalgam, approximately 0.4 of a centimeter in circumference. The average mercury release was 15 micrograms per day, which is half of the allowable all-source dose of mercury, according to the EPA. Mercury loss was by evaporation, electrochemical mechanisms, and mechanical wear. Average patient, say the average patient that we see in our office, say 8 amalgams of this size, would then have about 120 micrograms per day. So there are various studies with various amounts being estimated as far as how much mercury has actually come out of these fillings. There was a corrosion study done by Pleva, who was in vitro. He estimated that they were receiving about 30 micrograms per day. But he made the statement that a transition of only 1 gram of gamma-1, which is your ratio of silver 2, mercury 3, this transition of gamma-1 to the 1-to-1 ratio over a 10-year period will release 170,000 micrograms, giving an exposure of 46 micrograms per day. In 1991, the World Health Organization stated that the general population is primarily exposed to mercury through diet and dental amalgams, with dental amalgam providing the greatest degree of exposure. Studies utilizing DMPS challenge doses, which have been talked about here, have correlated increases in urinary mercury with the number of intraoral amalgams and confirmed these WHO statements. Mercury excretion. So fecal excretions have amounted to 20 times the corresponding urinary excretion. Scari et al. Stated that an individual with an average load of amalgam would excrete about 60 micrograms for 24 hours, thus exceeding the existing World Health Organization standard of 45 micrograms per hour. Now, if we extrapolate back the 60 micrograms, and we know in the research that approximately 80% of the mercury is excreted via the feces, then we could say there must have been a 75 microgram exposure to get this amount of mercury coming out in the feces. And there's no threshold of safety for mercury exposure. Both the EPA and the WHO have stated that there's no level below which mercury is safe. Most of us are familiar with the Vivian Lorscheider team out of the University of Calgary in Alberta. They put some amalgams in sheep. In this particular study, in fact, this is the first study they did with sheep. There's a combination of several studies right here, but the first study they used about 12 amalgams. 10% of the mercury in the alloy itself was a radioactive tracer. This is a man-made alloy, has a half-life of about 60 to 80 days. There's no possibility of contamination, none whatsoever. The mercury uptake routes were through the lung, the oral tissues, jawbone, and the GI tract. They found the mercury accumulated in virtually all the tissues of the mother, and then later on, the next study they did with the pregnant sheep, and they found that it was also in the fetus in virtually all tissues. And they found the pituitary gland had one of the highest mercury levels. They went on to study not only sheep, but they went on to study the primates. If you look closely, you can see the primate here. Here's the outline. Actually, I couldn't find the my article at home with the sheep picture in it. So this is the one with the monkey. But you can see that there's the jaw with a certain amount of mercury deposited, and there's the kidneys there. Now this kidney is overlapped with part of the GI tract. They had a series of 3 pictures, and one of them they took out the GI tract, and you could very clearly see the mercury deposition in the jaw and the kidneys. Very clear. There are some alternate pathways to the central nervous system from dental amalgams. One of them is called retrograde axonal transport. The nerve bodies transport neurotransmitters and various organelles even, but certainly many polypeptides from the nerve body down the axon to the nerve ending. And there's also a retrograde transport of things back to be recycled. What they have found, in fact, Arvidsson has about a half a dozen studies on this. They've demonstrated very clearly that there's a retrograde transport from the nerve endings to the nerve body, and then even deposition in the ganglia and the brainstem itself. What Arvidsson did in one of his studies is he placed an amalgam in the first molar of a rat for 3 to 9 months. After that time, he found mercury deposited in the trigeminal ganglia. He also injected mercury chloride in the first molar pulp of a rat. After 1 to 24 days, he found mercury in the trigeminal ganglia. So we know that we're getting this retrograde axonal transport. So you can extrapolate this information and say the mercury in the oral tissues, the bone marrow, the soft tissues, all of these have nerves. That can be retrograde, undergo retrograde transport back to the brain. Another alternative pathway is the valveless venous cranial pathway. Most of us were taught that all veins have valves for unidirectional flow of blood. However, there is a valveless venous system that goes up and down our spine, and there's a very rich plexus of these valveless veins in our pelvic area and our cranium. Dr. Storterbrecher in Europe has done a lot of study on this. He initiated the principle of the shortest pathway, and he demonstrated that by injecting a rat incisor pulp with a contrast medium, that he could find this contrast medium in the intracranial venous system, in the venous sinuses, and the central veins of the brain. In a human study using a cadaver, he injected in the mandibular marrow space. He found the same demonstration. The implications for root canals is very obvious here. That's not my topic of conversation, obviously, but one can do the same thing. Here's his slide from his book. In fact, Bioprobe has this book. Ed, do you have this book, Storterbrecher's book, by chance?
Oh, yes.
Okay. He is injecting the contrast medium into the bone marrow of this cadaver, and you can see that this contrast medium is going all over the skull and into the brain veins themselves. Here's a ventral view. It's very clear this is not staying in the jaw. Those are two pathways that simply aren't even discussed in organized medicine or organized dentistry. That means we're unorganized. Is that right, Ed?
It's a chaos theory.
Okay.
Seems to be working.
Human autopsy studies have shown a strong positive correlation between the number of amalgams in the mouth and mercury levels in the brain, pituitary gland, liver, kidneys, and lung. Quite a number of these studies. And I haven't listed all of the references. I've listed those that I thought were significant, and that's my own opinion, of course. I've used more extensive references, perhaps, than we would need here at this meeting, because I may be sharing these with conventional dentists, and of course, they'd like to string me up. Okay, symptoms from mercury exposure. Now, some of us like to taunt our peers by running ads in the paper, and some people will actually list these symptoms. And frankly, you'd be safe if you want to list these symptoms in the paper, because the source of these symptoms as being caused by mercury is the Journal of the American Dental Association, ADA News, and the JADA again. So even the American Dental Association knows that mercury can cause these symptoms. The ZIFs have put together a pamphlet that lists a large number, in fact they have 3 pages of pamphlets, symptoms. Lists a large number of symptoms from several references. But if you look at this first title here, psychological disturbances, this is basically including a definition of erethism. How many of our dental friends can be put in this category of irritability, lack of self-control, anxiety, nervousness, lack of attention, fits of anger, loss of self-confidence, depression, insomnia, decline of intellect? That's what hits me. Oral cavity disorders. How many of us have patients, pardon me?
ADA, they're in denial.
Yes, the American Denial Association, right? Yes, that's right. Okay. We're talking about gum disease here. We're talking about gingivitis, stomatitis, ulceration. Patients with any perio problems should not have amalgams in their mouth. Gastrointestinal effects. My sister had colitis and diarrhea for 9 years. It stopped the day I took her fillings out. Wish it worked for everybody. Cardiovascular disease, the #1 killer in our country. Neurological effects, headaches. We are a nation of medication takers for headaches. Headaches are not an indication of low blood levels of Tylenol or aspirin. Immunological effects, endocrine effects, and many other various symptoms. These are available in the ZIFS pamphlet, and many of us have that in our offices. And here's that pamphlet I was talking about. Dentistry without mercury. And there's other sources I'm using as well here, or they're using. As we know, the Swedish government has banned amalgam, initially for children and pregnant women, and soon, within a few years, for all people. One of the studies they did, in working towards this end, was a study where they did an amalgam exchange, as they called it. Yes?
Gary, that was banned last year, December of '93. Their dental association banned it
Totally now?
in Sweden.
Really?
Yeah.
Okay.
The government gave them a period of time, and the dental society said that they would just ban it period. So December of '93 it was banned.
So the ban is complete now. Good.
No.
No, no?
Come on, I am coming from Stockholm just now.
Okay.
It's like
Here we
this
go.
said, but I want to correct you on that, unfortunately.
Okay.
Because this has been now re-evaluated, and what they found is that they didn't improve at all. And the reason for that is, of course, that they did this amalgam removal before they knew what they are doing. So they put instead gold, and they left root fillings, and so on and so on. But unfortunately, just at present time, our physicians use these studies to prove that amalgam is completely sure. While politicians decided that it will be prohibited, doctors are still heading and singing there also.
So did this happen?
So this is used now to prove that
That it's safe.
Yeah, it's safe.
Well, thanks for that clarification.
They never give up.
Of course not. Our previous speaker talked about this briefly. This is the ZIF article that's appeared in the Bioprobe and also appeared in the Townsend Letter for Doctors. This is a partial symptom summary of 1,569 patients from 6 different studies. There were 762 patient adverse reaction reports submitted to the FDA, 519 patients from Sweden by Mats Hansen, 100 patients from Denmark from Henrik Lichtenberg, 86 patients in Colorado as surveyed by Robert Sibelrud, 80 patients in Canada, 22 patients in the USA by Dr. Zam. And we were just showing this a few minutes ago. I suppose the intriguing thing to me is to see how many of these patients actually had a specific problem. 45% had fatigue, of which 86% showed improvement. Almost a fourth had depression, of which 91% showed improvement. There are many symptoms here that would relate to either ourselves or our patients, hopefully ourselves in the past. As you know, mercury vapor is colorless, odorless, and tasteless. It's nonpolar and lipid soluble. Because of its liposolubility, it is readily absorbed. It crosses cell membranes. There is a significant increase in vapor pressure for every 1 degree increase in temperature. And we know that 75 to 90% of mercury vapor is absorbed into the lungs. To this lung exposure, we must also add direct mucosal exposure to the vapors. The liposolubility will allow the mercury vapors to go right through the mucosa into the blood vessels. There would be direct mucosal exposure to the ionic mercury from electrogalvanism as well. Microparticles of amalgam from abrasion within the GI tract. They can be highly toxic at molecular levels due to the high surface area and the microbial metabolism, as discussed, where we have methylation of the mercury going on.
Gary, do they have any studies on how it's absorbed in the skin besides the mucosa?
I'm not aware of that. I haven't looked at that, frankly. Once the mercury vapor, elemental vapor, mercury vapor is in the blood, it's readily oxidized to the ionic mercury formed by the catalase enzyme system. Elemental vapor reaching the tissues. In other words, that's circulating in the blood and it's diffusing all this time. It's diffusing into the cells and into the red blood cells, and those molecules that leave the blood vessel and into other tissues, in those tissues as well we have oxidation to the ionic form of mercury. The general reaction would be, as stated here, and it is an equilibrium reaction. They have fed animals ionic mercury, and they have off-breathed elemental mercury vapors. It's primarily dependent upon the redox status, I would suspect. In regards to dental amalgams, Clarkson, who's internationally respected, has stated that the ionic mercury form and the divalent cation form is believed to be the proximate toxic species responsible for the effects of inhaled mercury vapor. Other forms of mercury are also biotransformed to the ionic form we just talked about, even the various salts of methylmercury. Now, not all of them will go to ionic mercury. Some of them may complex before they're biotransformed. And the biotransformation is a slower process than with the mercury vapors. In 1990, Woods et al. Out of University of Washington proposed that ionic mercury conjugates with 1 or 2 glutathione molecules depending upon glutathione availability. Under ideal circumstances, with a limited exposure and adequate glutathione supplies, a ratio of mercury to glutathione, a 1:2 ratio, is formed which is excreted via urine and feces. With chronic mercury exposure and or glutathione depletion, a 1:1 ratio of mercury glutathione is formed by default. This form may still act as a free radical, perpetuating instead of resolving free radical pathology. Yes?
Why glutathione is contraindicated in diabetes?
Why is it contraindicated in diabetes? I'm not aware of that.
DMPS and glutathione is supposed to be contraindicated in diabetes.
Can anybody add to that? I wasn't aware of it myself.
I've heard that, but I don't know the pathophysiology, so I don't know that that's a fact.
Perhaps it's because it might do some benefit.
Diabetes, in diabetes,
In diabetes.
DMPS is blocking a lot of zinc, and zinc is important for insulin activation.
It's blocking what now?
Zinc.
Zinc. I see. Okay.
Zinc is very important for the insulin.
Well, diabetics are low in zinc. That's part of their concern then. Okay.
So add zinc.
Yeah, DMPS takes the zinc out as well.
Also use additional zinc for that.
Well, that would be our response, but they're more concerned about the obvious.
But they check insulin every day anyhow, so those people are under doctor's supervision. So they check insulin daily. So they add more units of insulin for 24 hours after you are able to add the zinc to their diet.
Makes sense to me.
Load them up on zinc first.
Sure. I've submitted an article to the American Diabetic Association on the complications of diabetes and the potential pathophysiological contribution of mercury from dental amalgams.
But you don't want to add anything 24 hours prior to giving DMPS.
No,
minerals.
that's right, correct.
And especially zinc. So even if somebody's low on zinc, you still don't
Right.
want to add anything, but you want to
Load-
increase supervision.
Load them up before and then cut off 24 hours and load them up afterwards.
That's right.
Whoops, I skipped one. Here's glutathione. It's our most prevalent endogenous antioxidant. It's a tripeptide consisting of 3 amino acids, glutamic acid, cysteine, and glycine. The active functioning part of this is the sulfhydryl or thiol group of the cysteine moiety. It is the most prevalent intracellular thiol in living cells. It participates directly and indirectly in numerous functions, as I'll show you shortly. It is the primary soluble intracellular low molecular weight compound providing a continuously maintained integrity of structure for living cells. Impaired glutathione status is being implicated in the pathogenesis of several diseases and degenerative conditions, especially those associated with free radical injury. Virtually every cell has a group of enzymes constituting the gamma-glutamyl cycle. This accounts for the synthesis and degradation of glutathione. The gamma-glutamyl cycle interfaces with a large number of metabolic pathways involved in glutathione utilization. It also serves in the storage, transport, and function of cysteine as well. A major portion of the primary degradative enzyme, the gamma-glutamyl transpeptidase, is located on the outside surface of the cell wall. Most glutathione is made within each cell from the constituents, as we discussed. So these constituents circulate by a cell, or the glutathione in the blood produced by the liver passes by the cell, and the degradative enzyme breaks down glutathione into its constituent amino acids. They're carried into the cell, and the cell is made within this. The cell makes glutathione within the cell. Now, the liver does produce appreciable amounts of glutathione. They're dumped into the hepatic vein or the bile at about a 3-to-1 ratio. And there's also been transepithelial transport demonstrated of intact glutathione within the intestines. This appears to be secondary, however. Excuse me. Intracellular glutathione is usually in the 0.5 to 1.0 millimolar range, more than 99% of which is in reduced form versus the oxidized form. Plasma glutathione, on the other hand, is usually in the micromolar range, of which about 90% is in reduced form. 67 to 90% of this glutathione produced by the liver is utilized by the kidney. Glutathione is specifically protective against nephrotoxins. Under conditions of oxidative stress, for example toxicity, the ratio of oxidized to reduced glutathione increases. And several organs have been demonstrated to release oxidized glutathione into the plasma. For example, the heart, the liver, and the kidneys. Yes?
How much glutathione do you supplement daily, just to clean up the kidney?
That's a good question. Frankly, I think part of that would depend. I usually test them, physiology, electric acupuncture. I'm using 2 or 3 N-acetylcysteine. I try to test them. The International Academy of Medical Toxicology is trying to put together a detox program. We're going to try and look at the research to see what ratios of cysteine, N-acetylcysteine, and glutathione might work well together for that specific purpose as a protective and detoxifying factor. So, frankly, I don't know the answer at this point. So, glutathione acts as a reducing agent. It donates a reducing equivalent, which is an electron with a hydrogen atom. It acts as and supports our oxygen radical quenching antioxidants, for example, the superoxide dismutases, glutathione peroxidase, and catalase. It also supports the dietary antioxidants we consume. It maintains sulfhydryl and disulfide status of proteins, especially enzymes. It protects against xenobiotic exposure. It neutralizes free radicals directly and non-enzymatically, for example, the Woods study regarding ionic mercury and glutathione, or indirectly and enzymatically, utilizing the cytochrome P450 and the glutathione transferase enzyme system. Excuse me. It participates directly in liver detoxification by the glutathione transferase enzymes I just mentioned. It acts as a coenzyme and as an essential cofactor. And the difference here, in one particular situation, glutathione is reduced and it donates its reducing equivalent to participate in the reaction, and then it has to be regenerated by the NADPH system. In other biochemical pathways, glutathione is added to a molecule and then it goes through a series of chemical reactions, at the end of which reduced glutathione is regenerated. And so it's like a pass key. It's like when you're traveling on a trip and you want to stop to use a restroom. It's kind of a silly analogy, but I like it because you stop, you go get the key, it lets you open the door and get in there and use the restroom, come back out, you give the key back in the same condition. Same thing with glutathione. It's merely a pass key that allows some reactions to occur. Ample research confirms that ionic mercury, complexes with glutathione. It reduces glutathione tissue levels and limits its availability for other function, and this potentiates oxidative injury. In addition, ionic mercury and other forms of mercury inhibit virtually all of the enzymes of glutathione metabolism. Glutathione synthetase, which is part of the gamma-glutamyl cycle. Glutathione reductase, which recycles oxidized glutathione. Glutathione peroxidase, which is our primary defense against hydrogen peroxide and endogenous lipid peroxides. And glutathione transferase, which is specifically involved in many liver detoxification systems, as well as involved in transport and metabolism of, for example, sex hormones. Some of the sex hormones are transferred specifically after glutathione transferase attaches a glutathione to the molecule and is transported between different portions of the enzymatic chain. Enzyme inhibition has long been recognized as a major property of mercury in biologic systems. For example, cytochrome P450, the superoxide dismutase, the sodium-potassium ATPase, calcium ATPase, catalase, lactic acid dehydrogenase, creatinine kinase, isocitrate decarboxylase. And this is mere sampling. There's a number of references, and I could have gone on with this. One thing to keep in mind as we talk about this is that the cell has an estimated 5,000 chemical reactions per second to maintain life as we know it. And most of these reactions are mediated by enzymes, more than a third of which are entirely dependent upon sulfhydryl status, either within the protein itself or the protein thiol status of the cytoplasmic melee within which they function. We're not just talking about enzymes. We'll talk about other proteins in just a minute, but the mechanism of action on these and other enzymes is an increase in oxidized glutathione or a decrease in reduced glutathione, which inhibits protein synthesis. This alters critical sulfhydryl disulfide exchanges required for the activity. Both initiation and elongation of protein synthesis are glutathione dependent. This alters the primary and the secondary protein structure. The tertiary structure is dependent upon sulfhydryl activity, disulfide bonds, and then again the status of the cytoplasmic melee. The folding of the protein chain upon itself to form a three-dimensional structure is very dependent upon glutathione and the cytoplasmic thiol status. The quaternary structure, where two proteins are brought together, is often dependent upon disulfide bonds between the two component proteins. The susceptibility of these sulfhydryl and disulfide bonds depend upon the stereochemical availability to oxidants, the chemistry of adjacent chemical structures, and the chemistry of the cytoplasmic or plasma melee. For example, albumin is a very large molecule with at least one sulfhydryl group available to act as an antioxidant. It's a backup antioxidant. However, it takes a very potent oxidant to reach this site because there are other molecules that they sort of run interference, if you will, to prevent other oxidants from getting to this site. So it can be the stereochemistry or the mere size of the molecule that prevents its oxidation. As I mentioned, we're not just concerned about enzymes. Here's two proteins that we're concerned about, and these specifically relate to diabetes. Insulin consists of two polypeptide chains. There's one disulfide bond within the A protein, two disulfide bonds between the A and B proteins. The insulin receptor has two alpha and two beta proteins. They are in series within and spanning the cell wall with a disulfide bond between each subunit. In other words, we have four proteins, two alpha and two beta. And not only are they held together by disulfide bonds, but we have the proteins sticking out into the extracellular space and intracellular space. So it's spanning the wall, the cell wall. So the insulin receptor in particular is not only dependent upon disulfide integrity, but on the integrity of the cell membrane, which mercury can also disrupt. We'll talk about that later. Glutathione peroxidase is an extremely important molecule. And one thing that I think about whenever I think about glutathione peroxidase is that it's very much involved in detoxifying endogenous peroxides. In other words, we have hundreds of millions of cells that are being destroyed and rebuilt every day. In so doing, we're breaking down various chemicals. We are generating peroxides within our cells as other cells are being destroyed. Glutathione peroxidase is there to help handle those. So the glutathione peroxidase takes two peroxide molecules, complex peroxides, utilizes two reduced glutathiones, turns them into water or alcohol, and oxidized glutathione, which has to be regenerated. It can utilize these complex peroxides as well as the simple hydrogen peroxide. We compare that to catalase, which mercury also can inhibit. Excuse me, one slide ahead of myself. Glutathione peroxidase is also selenium dependent. Selenium is a redox active cofactor which binds to mercury in a 1-to-1 molar ratio. This does not seem to affect the excretion of mercury or selenium, but it does render selenium unavailable to participate in the glutathione peroxidase enzyme. We compare that to catalase. catalase is limited to hydrogen peroxide, and this is important obviously, but it's not as diverse. Mercury inhibits both catalase and glutathione peroxidase. I've mentioned free radicals. We're not just talking about glutathione and mercury. We're talking about altering a system in such a manner as having too many straws in the camel's back. Mercury is adding a lot of straws, and our antioxidant system is suffering for this. So we're talking about free radicals or anything else that disrupts the thiol status or the antioxidant status. So free radicals, what are they? They're an atom or a molecule with an unpaired electron, generally in its outer orbit. This unpaired electron confers electrophilia upon free radicals. These free radicals want to steal electrons from other molecules in biologic systems. Free radicals have been implicated in over 100 diseases, including cardiovascular disease, cancer, AIDS, arthritis, diabetes, aging, and several of the neurodegenerative disorders. For example, Alzheimer's disease, multiple sclerosis, amyotrophic lateral sclerosis, Parkinson's disease. All of them have been demonstrated to have either or reduced levels of glutathione or reduced levels of activity of glutathione peroxidase. Unpaired electron confers whoops, I pushed the wrong button. Sorry about that. A number of metals readily steal electrons from molecules and then transfer them to other molecular species. This electron transfer is generally the basis of metal toxicity. The mechanism of toxicity of mercury and other heavy metals most often involves this electron transfer with sulfhydryl or disulfide groups of functional biological molecules, for example, enzymes. The first line of defense against free radicals, including mercury, is glutathione. Okay, there are many reasons for increased free radical exposure or production in our contemporary world. For example, we have stress, pollution, various xenobiotics, decreased oxygen concentration. That's a question mark. Stress, especially chronic stress, alters the chemistry of energy metabolism, generating free radicals. Pollution from civilized lifestyles generates chemical exposure. The National Resource Council states that about 70,000 chemicals are used in industry and commerce, and that no information was available on any aspect of the toxicity of approximately 80% of these. We are the guinea pigs. The Office of Technology Assessment states that more than 65,000 chemicals are in the U.S. Environmental Protection Agency's inventory of toxic chemicals. The agency annually receives approximately 1,500 notices of intent to manufacture new substances. We are inundated with chemicals. A few xenobiotic species enter the organism as relatively stable free radicals. Most become converted to radical species in vivo by non-enzymatic mechanisms or autooxidations, or by intracellular oxidizing enzymes. Synergism between endogenous free radical production and xenobiotics from food and chemical sources is a serious burden on protective antioxidant capacities. Reduced ambient oxygen concentrations, especially within the major cities. The average oxygen concentration is about 19% in North America. In most cities, it's around 17%. In the large cities, on bad pollution days, it's down to 12%. This is a concern because oxygen acts as an electron sink, which receives electrons generated by the respiratory electron transport chain during the production of ATP. There have been studies saying that the oxygen concentration may have been as high as 30% or more before the turn of the century. The sequential reduction of ground state oxygen with 2 unpaired electrons to water generates several radical oxygen species. In this sequential addition of electrons, you can see that at every step an electron is being added to the previous form of oxygen. It's my own opinion that aerobic respiration is advantageous to to us because, in part, it can receive electrons and sort of mop them up, if you will, or it's a sink. It receives electrons, and although oxygen-free radicals have been formed, we have enzyme systems to protect us against those. And we have more protection against the oxygen-free radicals than we have against the various xenobiotics themselves. Common free radical mediated reactions include sulfhydryl and disulfide reactions at single or multiple sites, protein cross-linkage, lipid peroxidation, LDL oxidation, cell membrane depolarization, and DNA fracture. Free radicals are also essential for life. They are involved in energy metabolism, phagocytic cellular destruction of microbes and foreign substances, prostaglandin metabolism, the complement cascades, oxidation reduction of metabolic reactions, detoxification of xenobiotics. So free radicals are a tool. Just that we're overwhelmed nowadays. Now let's go on to some specific metabolic pathways that are dependent upon glutathione. DNA synthesis is glutathione dependent. Ribonucleotide reductase reduces all 4 nucleotides, which is the first step in DNA synthesis. Glutaredoxin is the glutathione-dependent hydrogen donor. So the glutaredoxin system transfers a reducing equivalent from NADPH to ribonucleotide reductase by glutathione. You take glutathione out of this picture, and the ribonucleotides cannot be prepared for DNA synthesis. An increase in oxidized glutathione strongly inhibits this system, and glutathione depletion results in an increase in oxidized glutathione levels. Amino acid transport is glutathione dependent. The gamma-glutamyl transpeptidase transfers the gamma-glutamyl moiety to L isomers of amino acids. Cells with secretory and or absorptive functions have increased activity of this enzyme, notably mammary gland tissue, where there's a lot of amino acids being pumped into the milk for the baby. There's a lot of activity of gamma-glutamyl transpeptidase. Heme synthesis is sulfhydryl dependent. Hemes are made of porphyrin ring and iron. Hemoproteins perform many essential biochemical functions. Hemoglobin, of course, is the red blood cell oxygen carrier. Myoglobin is the muscle cell or the sarcoplasm oxygen storage. Cytochromes are involved in mitochondrial electron transport. The peroxidase and catalase are involved in peroxide neutralization. The cytochrome P450 is involved in liver detoxification of xenobiotics. All of these are hemoproteins. Heavy metals, especially mercury, alter normal heme metabolism. Mercury inhibits the rate-limiting step of heme biosynthesis, and at the same time, it enhances the rate-limiting step of heme degradation. It's a double whammy on heme synthesis, heme metabolism. The glyoxylase system is glutathione dependent. This catalyzes the conversion of methyl glyoxal to D-lactic acid via the intermediate S-D-lactoglutathione. It consists of 2 enzymes and uses glutathione. Most of this system is in the cytosol, some is in the organelles. It's found in all life forms. Its activities change around the mammalian cell growth cycles. It has a functional role in neutrophil activation associated with modification of microtubular cytoskeleton. We know that mercury disrupts the microtubular cytoskeleton. This system may transduce functional signals to the microtubule cytoskeleton through the influence of S-D-lactoglutathione. In other words, this system is involved in intracellular communication. It's involved in the cell growth cycles and activation of various different cells in the body.
Is that the reference on the microtubules on the bottom there?
Oh, let's see. No, it is not. That's coming later, I believe.
Okay, thanks.
If not, I've got it. Glutathione protects against free radical mediated lipid peroxidation. Glutathione acts as an inhibitor and repair mechanism via glutathione peroxidase of peroxidation-induced damage. Lipid peroxidation results in increased cell wall permeability. It disrupts transmembrane electrochemical gradients It depolarizes the cell wall, and it renders cell wall transport enzymes non-functional, which are also dependent upon the stereochemistry of the bilipid layer. Many authors report mercury-induced lipid peroxidation. And this is a sampling. There are many authors that report that. There's a few more. Activation of thyroxine T4 to T3 is glutathione dependent. Monodeiodinations activate T4 to T3. The deiodinating enzymes also degrade T4 and its other degradative products. In other words, T4 has 4 iodine molecules. A very specific monodeiodination occurs. One particular iodine molecule has to be removed for it to be the active T3 form. If it's any one of the other 3, it's non-active. It's a degradative product. It's a waste product. There are at least 3 iodothyronine deiodinating enzymes, and they all require thiols, especially glutathione, as cofactors. Glutaredoxin is very likely another cofactor involved in this enzyme system, and as I've mentioned earlier, glutaredoxin is also glutathione dependent. Arachidonic acid metabolism is also glutathione dependent. Alterations in glutathione concentration affect the profile and quantity of arachidonic acid metabolites. Prostaglandin synthesis is dependent on glutathione, the concentration of glutathione, and the concentration of the peroxides in the cytoplasm. Cytosolic peroxides activate prostaglandin synthesis. Glutathione transferase metabolizes endoperoxide and hydroperoxide metabolites of arachidonic acid in prostaglandin synthesis. Leukotriene synthesis is glutathione dependent. The availability of leukotriene precursors and the profile of the leukotriene formed, there's many different leukotrienes, and the type of leukotriene formed are dependent upon the concentration of glutathione and the extent of glutathione peroxidase activity. Glutathione transferase is also a component of the leukotriene synthetic pathway. Thank you. Leukotriene induces increased liver glutathione efflux. In other words, not only does glutathione affect the form of leukotrienes being manufactured, but specific leukotrienes will also induce increased liver glutathione production. This increases the extracellular or plasma glutathione and increases its availability at the sites of inflammation and helps detoxify the oxygen radicals involved in the inflammatory process. Insulin release is glutathione and thiol dependent. It has been repeatedly demonstrated that insulin release in response to glucose is related to the redox state of islet thiols. Glutathione allows appropriate thiol disulfide exchanges. Ionic mercury is one of the most potent sulfhydryl binding agents capable of modifying the insulin-glucagon metabolism. Glutathione enhances insulin secretion in elderly subjects with impaired glucose tolerance. The mechanism behind this sulfhydryl-initiated insulin release is mediated by changes in calcium concentrations within the cell, inhibition of potassium efflux out of the cell, with subsequent cell membrane depolarization to threshold potential. I'll talk about that. For example, calcium metabolism. Active calcium extrusion and sequestering is via enzymes within the cell and organelle walls. So we talked about earlier during the previous lecture, someone said, what's the definition of a dead cell? It's a cell without calcium. Well, to be more specific, calcium is pumped out of the cell or it's sequestered within specific organelles within the cell. And then if there's a failure in the system, the calcium levels within the cell go up. And cell death is often mediated by the concentration of calcium within the cell. But the enzymes involved in either sequestering or extruding calcium are the calcium ATPase and the sodium calcium transport enzymes, and they are specifically sulfhydryl dependent. Heavy metals, especially mercury, ionic mercury, inhibit intracellular calcium transport. And as I mentioned, various physiologic functions are in fact mediated by the changes in organelle cytosol calcium concentration. Yes?
Shouldn't that be the reason that we shouldn't use the calcium supplements during the mercury toxicity?
Some people believe that calcium also binds to some of the toxins and microbes we have in our system. I suppose there again, you go by testing. I don't have an answer for that. Anybody have an answer for that?
The question, the real question is, do you need a lot of excess calcium supplementation?
Right. All the general diseases have excess calcium, everything. So what you should actually go into is to balance the calcium utilization as opposed to add more calcium and add more towards the problem, because calcium is there. That's why you have joint pains, you have muscle pains, you have all sorts of.
I suppose that to me the bigger question would be what's happening to the calcium that's there. What form of calcium are we giving them?
This is what you do. I think it comes more from bad calcium
Yeah.
utilization.
Yeah.
And factor like this, and calcium is there, but it's not used by the body, no matter how much you're going to add.
I haven't studied that. Yes.
Supposedly, 1/10 of the Earth's surface is aluminum. Plants are subject to aluminum poisoning unless they have enough calcium. When they have enough calcium, it's not a problem at all. I think there's also good and bad calcium.
Yes.
A lot of the calcium we're measuring is not good calcium. It needs to be displaced by good calcium.
That's
Inorganic calcium from dairy products and everything else that is being deposited.
well. It's the analogy is just because I'm a human being, I can sit in the jet pilot seat, but I sure can't fly that jet. Where another human being who's been trained can fly it, and so there's inactive and active calcium, and what we need to find out, ideally with some type of testing, kinesiology or electroacupuncture, whether or not they need calcium, and if that calcium is in fact a form that's good for them. That would be ideal, I suppose.
Well, I don't know if you're familiar with Page's research on calcium and phosphorus balancing, but you can, without adding calcium, you can balance calcium and phosphorus doing the
Glandular therapy?
Yeah, I mean, going towards something else.
I see. I'm not familiar with that, no. Yes.
Harold Hawkins' work in the 20s, 30s, and 40s at USC, 15 factors that controlled calcium level in the saliva, which is the best indicator of calcium level in the body. Calcium intake was only one of the 15.
Is that right?
The other was potassium, chloride, phosphorus, bile, iodine, all these other factors.
Right.
I think calcium is something that we should, you do a lot of research, maybe that should be your next project.
I'll put it on my list.
It's a very controversial issue, and
Yes.
it is found in any average degenerative diseases, excess calcium in all sorts of tissue, deposited everywhere. And
I propose that would be calcium mismanagement at a molecular level. That's the question. What's causing the calcium mismanagement? It could be energetics, it could be a lot of things.
dysfunctioning of the glands in the body, like
Yeah.
thyroids, posterior and anterior pituitary.
Sure.
That's for the example.
Yeah.
Okay.
Makes sense. The sodium potassium enzymes are also sulfosylation dependent. We're going back to our insulin release now, okay? It was mediated by two factors, cytosolic calcium concentrations, and by the timing of and the intensity of potassium release. Okay, so the sodium potassium ATPase transport enzyme is in the cell wall. It pumps out 3 sodium and 2 potassium into the cell. As it does this, maintaining this ionic and electrochemical gradient, it is utilizing 30% of the cell's ATP to maintain this electrochemical gradient. It's the basis of molecular transport for ions, sugars, and amino acids. Mercury inhibits this transport enzyme. So specifically for insulin release, if we have a dysfunction of the sodium potassium ATPase transport enzyme, and we have improper concentrations of potassium, then we cannot get the appropriate amount of efflux of potassium out to help trigger the release of insulin. Questions about the insulin before I move on? It was amazing to me how complex that was. I didn't know. Lipid metabolism may be glutathione dependent. Dietary glutathione decreases total cholesterol, triglycerides, and phospholipids in rats on high cholesterol diets. Lymphocyte activation and proliferation responsiveness to mitogens is glutathione dependent. Glutathione depletion lowers the mitogenic response. Addition of glutathione to culture reverses this depression. Age-associated impaired T-cell-mediated delayed type hypersensitivity can be reversed with glutathione supplementation. cell growth and differentiation is glutathione dependent. A glutathione threshold has been observed that determines what type of interference is going to occur. This interference is based upon multiple mechanisms: reactive oxygen species, enzyme inhibition, cytoskeleton assembly disruption, and macromolecule synthesis. Glutathione protects organs from toxicity, protects the liver from ethanol-induced oxidative stress, which is mediated by acetaldehyde and involves the generation of free radicals, protects kidneys from xenobiotics, including mercury. I'm going to skip 2 slides here and go right on. Okay. There are a number of systemic health disorders about which we have a significant amount of research, at least implicating mercury, if not actually indicating a causative role for mercury. In my book, I have 8 topics with 40 to 50 references per topic, and I just thought I picked out some of my information and updated it with some new information, so I'll try to get through this as quickly as I can here. Alzheimer's disease. The University of Kentucky Medical Center and a European study as well, they have about 5 studies demonstrating the highest elevation of any trace metal in the brain tissue of Alzheimer's disease victims is not aluminum but mercury. We have abnormal microtubule formation in Alzheimer's disease brain tissues associated with increased neurofibrillary tangles. Mercury alters tubulin metabolism in rat brain tissue similar to that of Alzheimer's disease. Durer stated, these results suggest that certain complexes of mercury or ionic mercury must be considered as a potential source for the etiology of Alzheimer's disease. Mercury disrupts the microtubular structure and it inhibits tubulin synthesis. So there's 2 ways in which it can impair that. Mercury selectively inhibits the uptake of synaptically released glutamate, results in an elevation of extracellular glutamate levels. Elevated glutamate levels have been reported in the brain tissue of Alzheimer's disease as well as in the cerebrospinal fluid. An environmental or occupational exposure to mercury that is of itself insufficient to cause overt CNS toxicity by diminishing the safety factor for inactivation of glutamate could nevertheless accelerate processes of excitotoxic neurodegeneration associated with disease or aging. Silent impairment of this kind is suggested by the delayed emergence of neurological dysfunction following remote occupational exposure to elemental mercury vapor. In other words, mercury is doing damage that clinically we cannot determine, but subclinically the progressive degeneration goes on. So mercury inhibits neurotransmitter uptake, this glutamate in this case.
So it's the extracellular glutamate is reflecting the fact that it's not inside the cell, or should be?
Yes. Yes.
Kidney studies. We've had a number of kidney studies. There's a sheep study was done by Vivian Lorscheider in Canada. They placed 12 occlusal amalgams. Within 60 days, the average loss of kidney function was 60%. Human study. This is a Mullen study. Could someone focus that for the references by chance, that tilt? The Mullen study was actually published as a support of the safety of amalgams in Europe. But what they did, they had 10 subjects and they had amalgams and removed them. They took tests before and after. But they found that after 12 months after removal, there was a significant increase in urinary albumin levels. This was a reciprocal of the sheep study, where they found a decreased urinary albumin level when they placed the fillings. So the studies confirmed themselves from 2 different directions. Rabbit and rat studies. The proximal tubule is the primary site of mercury accumulation. The probable mechanism is the mercury-induced reduction in blood flow to the glomerulus. Kidney disease. Ionic mercury induces autoimmune glomerulonephritis in all species tested, but not in all strains. So no, there's genetic variation, obviously. Mercury chloride induces circulating autoantibodies and immune complexes involved with IgG deposits. Kidney disease. The National Institute of Occupational Safety and Health states, kidney damage may result from excessive exposure to mercury as manifested by the nephrotic syndrome of edema, proteinuria, and the presence of casts or cells in the urine. Such damage may or may not be accompanied by an elevated mercury level in the urine. Nephrotic syndrome may be the only manifestation of mercury intoxication, and recovery from the nephrotic syndrome usually follows removal from exposure. In more severe cases of kidney damage, renal failure and oliguria may develop, leading to complete anuria. Kidney disease. Our master safety data sheets, which we're all supposed to have, at least in North America, in our offices, list kidney disease or symptoms specifically for mercury vapor. Nephritis, nephropathy, kidney damage may be indicated by proteinuria, albuminuria, enzyminuria, and anuria. Reproductive disorders in men. There are lower rates of fertility in men exposed to mercury vapor. Decreased percent of motile sperm in response to mercury. Mercury interferes with spermatogenesis. Mercury inhibits DNA synthesis, RNA synthesis, and meiosis. Mercury interferes with testosterone production. I'm going fast because I'm running out of time. Reproductive disorders in men still. Selenium is preferentially accumulated in the testes. It's incorporated into the developing spermatozoa. Remember, mercury binds to selenium. Rats fed a selenium deficient diet produce sperm with dysfunctional motility and pathologic damage. Mercury depletes glutathione. Mercury inhibits glutathione, the enzymes of glutathione metabolism, which alters the redox potential and thiol status, leaving the oxygen radicals unquenched. This potentiates free radical pathology. This impairs sperm motility and competence. 40% of semen with sperm from infertile men have reactive oxygen species at higher levels than people who are fertile. Okay, in women, menstrual cycle abnormalities amongst women, mercury-exposed workers. Includes two groups of dental workers. The rest of them are non-dental. Most of these are European studies, most Eastern European. Mercury contributes to increased rates of spontaneous abortion. Let's see. In 1981, Gordon stated, "It does therefore seem that female dentists who work have a higher than expected incidence of spontaneous abortion and premature labor and perhaps a higher perinatal mortality." 1982, Kunst stated, "Previous stillbirths, as well as a history of birth defects, exhibited significant positive correlation with background mercury levels." Those are blood mercury levels. In 1994, the EPA stated, "Women chronically exposed to mercury vapor experienced increased frequencies of menstrual disturbances and spontaneous abortions. Also, a high mortality rate was observed among infants born to women who displayed symptoms of mercury poisoning." Lamperti et al. Injected hamsters with mercury chloride, radio-labeled mercury, demonstrated mercury deposition in the corpora lutea of the ovaries with direct inhibition of ovulation, as well as deposition in the hypothalamus gland and pituitary gland with indirect hormonal dysregulation. Smith, on reproductive toxicology, suggests xenobiotic disruption of hormonal pathways. Gerard and Runenbaum in 1987-89 studied 419 women with hormonal disturbances. 50% had elevated creatinine, indicating some kidney problems. Many had elevated mercury in saliva. Patients with alopecia, polycystic ovaries, hyperandrogenia had significantly higher urine mercury levels. Pesticides and mercury caused reduction in fertility via endocrine disturbances. 70% achieved pregnancy after detoxification. Prenatal mercury exposure. We've already seen it in the World Health Organization and EPA statements. There can be some perinatal problems as well. Fetal brains accumulate mercury, especially mercury vapors. The placental barrier is more restrictive to mercuric salts. Studies on human, sheep, and rats demonstrate that mercury from intraoral amalgams is deposited into fetal brains. Mercury decreases in fetal nutrient uptake, vitamin B12, zinc, aminobutyric acid. Mercury inhibits fetal glucose 6-phosphate dehydrogenase. This is involved with many key enzyme pathways: the energy cycle, carbohydrate metabolism, the biosynthesis of fatty acids and steroids. Fetal organogenesis can be seriously compromised. Histopathological changes in fetal and neonatal brains demonstrate disoriented pyramidal neurons in the cerebral cortex, growth retardations, sulci abnormalities, and an increase in number of heterotopic neurons in the cerebrum. Behavioral changes, alterations of spontaneous motor activity, hypoactive at 3 months, hyperactive at 14 months. Translate this into our own kids. Our kids hyperactive teenagers, hyperactive rather. Altered spatial learning, reduced ability to adapt, behavioral changes, similar to those reported in offspring exposed to methylmercury in the Minamata studies. This study is rather amazing. Autopsy study of 108 children ages 1 to 5 years old, as well as 46 fetuses. The brain mercury of infants and fetuses correlated the number of mothers' amalgams. These abortions had mainly been induced for medical reasons. All infants had died suddenly, and most were diagnosed as sudden infant death syndrome. So the SIDS babies have a higher elevation of mercury than non-SIDS accident victims, and the SIDS babies' brain mercury levels correlates to the number of amalgams the mother has in her mouth. Immune system dysfunction. 1974, Trachtenberg, she wrote a 330-page summary of work done in Russia, and this is just one of her sections here. Thus, prolonged action of low mercury concentrations on mammals leads to changes in a number of immunological indicators: agglutinin titers, active leukocyte percent, phagocytic number, complement activity of blood serum. The dynamics arising under the influence of toxic effects of immunological shifts is characterized by 2 periods: initial short-term stimulation of immunological response and by a subsequent stronger suppression. There is a significant decrease in the preventative properties of the blood obtained from immunized animals subjected to chronic action of mercury. Mercury induces antinuclear antibodies, polyclonal B cell activation, resulting in autoimmunity, autoreactive T cells, antibodies to glomerular basement membrane, antibodies to anti-neutrophil cytoplasm. Karen, in 1970, stated low doses of both immunogenic mercury and organic mercury caused an alteration of lymphocytes from humans allergic to mercury. Druitt, in 82, immune disease caused lesions in kidneys, spleen, intestines, liver, lungs, and heart. Numerous forms of mercury could cause disease regardless of its route of administration. Druitt, in 82 rather, Druitt's done a large number of studies on mercury toxicity. Mercury modifies immune homeostasis in rats. As a result, autoantibodies are produced, some of which are of pathogenic significance. Allergy to mercury and or other components of amalgam. There have been a number of studies beginning in, a number of studies beginning in 1969 with Gerasi and Barova. North American Contact Research Group in 1973, they had 1,200 subjects. This is 225 subjects. Brun in 75 was 1,000 subjects. Niebenfuhr in 83 with 1,530 subjects. Mobach in 84. Osman 94. The incidence of allergy to mercury ranged from 5% as high as 33%, depending upon the population studied. Here's your references there. I'm sorry, we're officially out of time, but I'm almost done. Mercury allergy in dental students. Of course, the ADA is always saying there's no problem with allergy, right? Only 50 case reports of allergy to mercury since the turn of the century, I think is their quote. Miller et al. At Baylor College of Dentistry in 1987, students with positive skin patch tests had an average of 9.5 amalgams. Those with amalgams more than 5 years old had 31.6% positive rate. Those with amalgams more than 10 years old had 44%.
Gary, it's interesting to know that if you do a DMPS challenge and then do your testing for the allergies, it's more like 90%.
Is that right? It's amazing. Is that written up anywhere? Or just?
Well, it's from Germany.
Schenker's put together a series of 4 articles. Starting in 92, he found that mercury-containing compounds are immunomodulatory. Moreover, the decrease in B cell function indicates that this metal is immunotoxic at very low exposure levels. High-level exposure may lead to cell death. Low levels of mercury may result in insidious effects associated with depressed immune function. Such alteration in host defense may be silent in that it may be difficult to delineate overt signs of immunotoxicity. Nevertheless, in subjects where the immune system is compromised, the presence of even low levels of mercury may exacerbate underlying disease. Cardiovascular disease. Mercury is deposited in the heart. I'll stop right there. I could say more. I'm running out of time. I'm out of time. Okay. In the early to mid-1900s, there were many reports of the cardiovascular symptoms resulting from mercury being used as a medicine. In 1960, there was a report on the cardiotoxic effect of mercury diuretics. Acrodynia, a syndrome caused by mercury, is the medicinal use of mercury chloride in calomel. It's used as a teething powder and for diaper rash. The cardiovascular symptoms included vasoconstriction, hypertension, and tachycardia. In 1974, the NIH published part of Trachtenberg's journal, or records of work, and they found significant cardiovascular dysfunction following chronic low-level mercury exposure. In Sibbelrud, 1990, Sibbelrud compared the cardiovascular status of subjects with and without amalgams. He found, again, significant difference, statistical difference between the two groups of amalgams, those with amalgams and those without. Diabetic complications. And I wanted to get to this. I'm almost done. If you look at all these complications, the cardiovascular disease, nephropathy, polyneuropathy, retinopathy, and cataracts, immune system dysfunction, reproductive complications, neurobehavioral disorders, skin and connective tissue disorders, periodontal disease, all of these have either a direct potential mercury etiologic factor or indirectly through free radical pathology. Diabetics have reduced glutathione levels, reduced ratio of reduced glutathione to oxidized glutathione, an impairment of glutathione metabolism, reduced activity of glutathione synthetase and glutathione reductase. Tagame states that the decrease in antioxidant activity may have significance in the spectrum of pathology associated with diabetes mellitus. Diabetics also display reduced antioxidant capabilities, reduced activities of enzymes with superoxide dismutase and catalase, reduced antioxidant levels of C, E, and uric acid. Diabetics are less able to compensate for further oxidant insult, for example, from mercury and other chemical exposures. Diabetics have an elevated level of free radicals. In fact, free radical pathology may have initiated initial beta cell destruction. And there we are. The diabetic article has been submitted to the American Diabetic Association. We'll see what happens. The glutathione article will be submitted very shortly. If you have any questions, I'll hang around after we close it down.
I have a question.
Yes?
Is this one that you're offering now an update from one you did last year?
No, it's the same one. I haven't had time to get all the stuff together in the book yet. I want to get about 4 or 5 more subjects and get them into the book altogether and get it republished.
Okay, so this is
This same as last time, yeah. So, thank you very much.
I want to thank you, Gary, for a lot of hard work that you've done. I want you to know that this particular lecture is protected by the First Amendment. This is for information only.
Well, I'm also a physician and dentist too, because we have another system as you have in the States here. We have first to go through the whole medicine and then we can go and specialize. For instance, gynecologist or dentist or each kind you want to specialize. So the government now wants to change because they don't want the dentist to know so much. So With this year, we started just to be a dentist, so we go just through 4 years of dentistry and no normal medicine. But they don't know how it will work. I mean, it's on the paper, but they can't work it out. That's the problem of the government at the moment. So we want to be mercury-free in the year 2000, and the reason, well, we had a prime minister, his name was Kreisky, and he lived very long in Sweden, and he wanted to make Austria similar to Sweden. So, except the high taxes we have got from Swedish government, we also had the hope to get mercury free. But as we had votes in, I think, 4 weeks ago, the Socialistic Party lost many votes, so we don't know really what's going on at the moment. But at the university in Vienna, we we are working together with Dandra from Munich, and well, we are trying. We have to, if the patient wants mercury, he gets it. But we make very good information. The patient gets paper so that he can study himself about mercury, and so many patients, they come, but they don't want any mercury fillings. And at the university in Vienna, they still teach mercury fillings, but the people, they don't want mercury anymore. So because in Germany, in Frankfurt, they have a university, and they stopped teaching mercury fillings. And the biggest company in Germany producing mercury stopped producing mercury for this year, and in Austria they also want to stop it next year. And we had a new law with the 1st of January this year that mercury is poisonous. But also we have this law, I mean, it's paradox. We have a law, but we are allowed to put mercury in the mouth, into the mouth. So, and we and we have to have this law hanging on the wall in the clinic. So we have a control system, and they come into my office and they have a look if I have it in the room for the patients. They come and control.
They come into your office.
Yes.
Make sure you have an ample supply of the makers of an amalgam.
Yeah.
Oh.
Yeah.
The amalgam,
Have you
please.
brought your amalgam this month?
Hey, you know, National Socialism, we're going to have the amalgam police. You wait and see.
Yeah, that's right. Yeah.
Incredible.
Yeah.
There may be more to that.
Yeah. But I mean, in Germany, we always are meeting at the medical week in Baden-Baden, and they seem to get worse, similar to the States, because they are trying to limit the production of homeopathic remedies, and they also want to limit the DMBS. That's new, so
Okay.
we'll see.
Anything else?
It's okay.
Thank you.
Yeah.
I think so. Something needs to be done. Maybe we're all going off to the wrong drummer or something. Still not too late to change sides. Any defectors? Walk out the door. Okay, they're all going to stay for it. We're over for this evening. Tomorrow morning at 9 o'clock, but we're going to have a no-host cocktail in the next room, or beer or wine, whatever. And then let's see, this evening, Jess Clifford's going to show one of his videos on cellular reactions to metals. And yes? Yes, it's an updated one, and I think a new one, right?
We have the one on the metallic reactions and also cell wall divergent microbiology.
Cell wall deficient
HRT?
microbiology. At about 8:15 tomorrow morning at 9 o'clock with Dr. Jaffe. One other thing here. The endodontist has sent out this announcement and abstracts. I'm going to run this by this group here. Do you think we ought to have a debate? In other words, write an official letter. Well, yeah, write an official letter to the Endodontic Society and ask them that we'd like to discuss each one of these points that they bring up.
Can't we just do it against Ned? He's part of the enemy.
These are the spies, so they send them over here as a spy. You know, they can't quit. It's like the CIA. Once in a company store, you're always there, you know. But anyway, do you think that's a good thing or that's not too professional or what? Raise your hands. Go for it or not. I mean, it's a meeting, you know. It might learn something.
The change is one guy, it's worth it.
First of all, I don't think they'll step up to the challenge. See, anytime you have some group challenge another group, it's like that fluoridation versus anti-fluoridationists. The people that are promoting fluoride won't discuss it, debate it with the anti-fluoridationists. So they ignore them by that way. Or they'll arrange a debate and they don't show up. So there's no debate. And the people that show up look stupid. Anyway, we're over for this evening, so let me know what you think about this thing. If not, we have another good meeting planned.
What Ed is talking about?
What this was, this is an extension of their position that root canal therapy is absolutely, positively safe. Okay? Dan.
And one of the things that occurs to me is that there are studies that they've done in this country to validate root canal therapy is basically very short term and so forth. I think that somehow the point ought to be made to them in a way that they have to come out of the woodwork and refute it. They have no longitudinal studies. They have no morbidity, mortality studies. And
well, this is the thing we need to talk about. We need to plan this thing. I mean, I think this will make the papers.
well, and the way I would do it is to, if Burton Goldberg would, he's always talking about his radio programs. I think that get him to address those issues on the radio programs and get it out there, so that people begin to ask them about these questions, because they're intimidated by any professional, but a lot of them are losing that intimidation factor, and so if people begin to ask those questions, it embarrasses the hell out of them, and they've got no place to hide. You're not going to do any good. I'm not going to do any good at confronting them because they just put a wall up and they say, yeah, give you that crap. But,
well, I understand that, but this information needs to be discussed openly,
Absolutely. But I'm saying, do it at grassroots is that's probably where we're going to have the most effect.
Just because they don't see what's happening doesn't mean it isn't happening.
Right.
So why don't we take a break now and get back to legacy.
Bob Atkins has a radio show in New York on the old...
Well, give me some information, feedback. If you don't do it now, write me a note when you get home or call me or whatever. Thanks. 8:15.